The purpose of this program is to give you an overview about ALS so that you can understand more about the disease as well as some of the resources available to you. This video is for educational use only. It is not intended to replace consultation with your healthcare provider.
So my favorite topic, treatment that works. This is what you came to hear about. All this other stuff has been preliminary. So treatment that works. I want to start by repeating this quote from Dr. Hiroshi Matsumoto and Dr. Forbes Norris. Dr. Norris, of course, is the founder of the Forbes Norris ALS Research Center where I work. And he was speaking to his colleagues when he wrote this back in 1994. There's a great deal that can be done to treat the symptoms of ALS, improve the quality of life of a patient, and to help the family cope with the disease. He was looking at symptomatic management, quality of life, and attention to the family. And he was speaking to his colleagues saying, don't send these people away. You can help them. And so that's the philosophy of care that all of the team clinics that are multidisciplinary team clinics, that they will have caring for patients with ALS. So I say ALS is a treatable disease. What does that mean? Can we cure it? No. We don't cure diabetes. We don't cure heart disease. We don't cure most medical conditions. But we can change the course of the disease, and we are doing that in ALS. And how are we doing that? We're doing that through evidence-based research, 4 things that we know work, and they're all in your control. They're all in the patient's control, all 4 of these things. Increases survival and quality of life. The first thing and most important is multidisciplinary team clinic. Go to a center that has a whole team. The people on this team will be experts in their own field, say they're physical therapists, but they'll also be experts in ALS. So it's very important. You get proactive care, and they discuss issues with you before you know that there is something that needs to be learned. Who's on that team? An ALS neurologist, nurse case manager, social worker, physical therapist, occupational therapist, respiratory therapist, dietitian, speech-language pathologist. That's the core team. Additional specialists that may be available would be the neuropsychologists. We have one research coordinator, me. Representatives from the ALS Association and the Muscular Dystrophy Association come to clinic to talk about what services they have to offer. An equipment specialist, someone who's a palliative care specialist, a genetics counselor. Wish we had one. Consultants, the team will have a relationship with specific gastroenterologists or pulmonologists that will take care of their needs, and they get to know ALS very well through working with the team. So team care, really important. Number 2 is nutrition. Remember how I talked about it's like running a marathon every day or going to the gym all the time? You got to feed the fire there in order to lose weight. So we know that losing weight in ALS can cause problems, and that maintaining weight can increase longevity. So both malnutrition and dehydration can adversely affect survival. Now, some people with ALS become hypermetabolic, and they will need 1,000, 2,000 calories, 3,000 calories more per day than they used to. We don't understand any way to predict who this is going to affect, but if you weigh yourself once a week and you're not getting enough food in to keep your weight up, then maybe it's because of activity, but maybe also it's because of hypermetabolism. And you need to just keep going and keep going with more food. But sometimes if you become so hypermetabolic, you just can't keep up. And then we say, just do the best you can. Just do the best you can. Have more meals, snacks in between meals, high-calorie things. We'll talk about that in just a second. If you go to a team clinic, they're going to give you proactive care. They're going to talk with you about how to prevent weight loss from the get-go. So, add calories wherever you can if you're starting to lose weight. Whole milk, creamy dressing, cream soups. Did I say creamy stuff? High-fat stuff? Oh, yeah. Mayonnaise. Do you have any idea how many calories are in mayonnaise? You know, you get that nice In-N-Out burger with the special sauce on it. Ask for extra sauce. Nutritional supplements, you want to use Plus on Ensure or Boost. Some people think Carnation Instant Breakfast tastes better. You want to use whole milk. Maybe use 2 packages in your whole milk. Smoothies, great things. Lots of snacks, never skip a meal. Soft, moist foods are easier for people who have any kind of weakness with chewing and swallowing. And here are just some pretty pictures. This is Ensure pudding. Look, it's got 240 calories and 5 ounces. That's going to pack a punch. I can't do that. Some thickeners for people who have difficulty with thin consistencies. And if you're going to use Boost or Ensure, make sure you get the Plus. It's got 100 extra calories in it. Now, some people can't keep up because they've got a lot of weakness here with chewing and swallowing. And then we're very glad that we have the opportunity, we have the technology about a feeding tube. So a feeding tube is put into the belly, goes into the stomach. There's a little bumper on the inside so it doesn't fall out, and there's a little bumper on the outside so it doesn't fall in. There's a connector here where you're going to put a syringe and then pour the food in, or use a bag where you pour the food into a bag and let it drip in through tubing right there. So when is a feeding tube indicated? You want to maintain nutritional status. You don't want someone to lose 20, 30 pounds and then think about a feeding tube. You don't want to chase your tail. Be proactive. But if people are coughing and choking with meals or even a little while after a meal, stuff is going down the wrong way. Aspiration pneumonia used to be a leading cause of death in ALS. It's not anymore. That's because we get feeding tubes in people when they are at risk. If people have a lack of appetite, such that they're losing weight, it may be an indication for a PEG. If it's taking so long to eat that the food is cold and you give up when it's only half there. Significant arm weakness, again, really having a hard time getting the food in. If eating's a burden, if there is already weight loss. Number 3 on the hit parade here of the 4 things in your control is non-invasive ventilation. BiPAP is a brand name, just like Kleenex is a brand name. So we try not to say BiPAP too often anymore in the clinic, but everybody knows BiPAP. When it is time to get non-invasive ventilation, embrace it as your best friend. It is your best friend. This has radically changed the amount of time that people live with ALS. You all maybe have heard about CPAP, continuous positive airway pressure, again a brand name, but it's for people with sleep apnea. I use CPAP. I had to get used to it. And the BiPAP, or non-invasive ventilation, is very, very similar, except there are 2 levels of air that come in. When you're inhaling, it's a high level of air that's breezing by, and when you're exhaling, the pressure goes down quite a bit so that you exhale against a lower pressure, so it's easier to exhale. When is it needed? It's needed when your maximum inspiratory pressure is less than 60 or FVC is less than 50% forced vital capacity, the blowout test. The MIP always drops first, and in our clinic, we test the MIP, and as soon as you qualify, then then we order non-invasive ventilation for you. What it does is it gives you a bigger breath without any more effort. What happens in ALS is that you start taking smaller breaths, and your lungs can get stiffened, and if you start non-invasive ventilation too late, your lungs won't be able to stretch out for that nice big breath anymore. So some of the signs and symptoms that might clue you that this might be helpful is you have difficulty lying on your back or lying in bed. You're taking more frequent breaths, so your respiratory rate is up. You're waking in the night more frequently. You think that you're waking up because you have to go to the bathroom, but maybe it's because you're not breathing well enough and your brain is saying, wake up so that you'll take a bigger breath. If you wake up tired in the morning or with a headache that goes away quickly, I could talk for a long time about the benefits of non-invasive ventilation and the rationale behind that, but I think in the interest of time that we need to leave it with this. Any questions? All right. So, number 4 is medications. So we talked about multidisciplinary team care, we talked about nutrition, we talked about non-invasive ventilation. I'm going to talk to you now about 2 drugs. Up until a couple of weeks ago, we only had one. I'm going to talk to you about 2 drugs that will slow down the progression of ALS. Riluzole was approved in the early 90s for ALS, slows things down by about 10% for the average patient with ALS. That's going to be about 3 months. That was in the initial study, and subsequent studies looking at the placebo group of other ALS studies and taking that placebo group and then stratifying it by people on riluzole, people not on riluzole. They found that the survival benefit was anywhere from 5 to 21 months. And that was because of the inclusion criteria in that initial study. The inclusion criteria in that initial study included a lot of people who had who had had ALS for a very long time. So you could have had ALS for up to 5 years. In studies today, it's 2 or 3 years, and you could have a breathing capacity as low as 50%, and in studies today, it's 65, 70%, 75%. Riluzole is aimed at protecting the nerve, so it gets hit later, right? So if you've lost a lot of nerves, you're not going to have as big an effect. So starting it early is really, really important. It's got very few side effects. About 80% of people never have any side effects, but about 5% of people can't tolerate the drug. It's not a good match for them. Cost is a factor. For the generic these days, it's about $2,000 a month. It's not a magic bullet. If you don't have insurance, then we suggest that you don't mortgage the house in order to take this drug. And here's the graph that was used. You can see the placebo group in white, the riluzole group in green, and it was an 18-month study because the endpoint measure was survival, very, very long study, and they diverged about 10% at the 18-month mark. Edaravone, Radicava. Radicava is the brand name being used in the United States. This drug has just been approved May 5th, 2017. It's approved in Japan and South Korea in 2015 for ALS. It's been on the market since the early 2000s for stroke. So the side effect profile is well known in stroke, not so much known in ALS. All of the 3 studies that were done in ALS were done in Japan. This is a Japanese company. They had 2 negative studies, but they saw a signal. They saw something in the last phase 3, in the first phase 3 study. They saw that some people seemed to do better. And who were those people? They pulled out those people and said, okay, for our next phase 3 study, the one that turned out to be positive, for our next phase 3 study, we're going to include only those people. And those people had a higher breathing rate. It was about 80% or higher. They were less than 2 years from onset, and they were progressing just a little bit faster than the average ALS patient. 137 patients, placebo-controlled, double-blind placebo-controlled, half and half. A short study, 6 months. So in order to get a change in the 2 groups, they had to do a very short, in a short study, they had to get people that were progressing a little bit more quickly. The results over 6 months, the drug group had a 33% slowing. That is significant. Okay, that is significant. However, here's the other shoe that's dropping. It's an IV-administered drug. The first cycle is 14 days in a row. It takes an hour in a vein to be given the drug. And then you take 2 weeks off. And then subsequently, it's always 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off, forever. The 2 weeks on turns out to be Monday through Friday. So you get a little bit of a break at that point. What we're looking at in the United States is that people will get a port similar to a port that it would be used for chemotherapy, and that probably this is going to be administered in the home through home infusion companies. But we're looking at cost, $145,000 per year. That is hefty. So MT Pharma America, that's the company in America that is marketing this drug. In Japan, the mother company is called Mitsubishi Tanaki. They are putting together they're putting together a group of people that will help us in the clinic to order it and to get insurance approval and all that, and a group of people that are for patients, and the patients will be able to, they're getting a group together for the patients so that they can call the company and they will have some hand-holding to help them get through the insurance process and answer questions and that kind of thing. Most common side effects, headache, bruising, or gait disturbances. I don't know exactly what that all entails, but that's what came out in the teleconferences that I've been listening to. But there are some rare but potentially serious side effects, mostly having to do with anaphylactic shock. That's like having an allergy to penicillin. Okay, some people that have sulfite allergies, and that might be bisulfates, metabisulfates, food allergies. If you've got that kind of allergy, you know it. And you could have an allergic reaction to metabisulfates. Kidneys and liver failure has been seen in this drug, so it needs to be taken clearly under a doctor's supervision. Looking at the data, MT Pharma was kind enough to supply me with 2 of their slides that I'm using here. You can see that Endaravone in the green, at the end of 6 months, they had, in the ALS functional rating scale revised, the patients started about the same at 33.6, 33.5, but the people who are on placebo dropped significantly more than the people who took the drug. They had a 3-month period of looking at people before they got drug, so here's that point here, and now they get the drug starting here. And by 3 months, they're starting to really diverge. So
Was
this
it blind?
double-blind, placebo-controlled study. So, to me, as a researcher, this means a lot to me. Okay. Another way of looking at that is to look at each individual patient. And those patients who were placebo patients are in the gold, blue for the edaravone patients. So how many points in the ALS functional rating scale did the patients change over 6 months of time? You can see that the blue patients are clumped up here, having changed very little, whereas some of the blue patients are down here, but there's a preponderance of the placebo patients that changed 11 points, 17 points, even up to 20 points in 6 months. Those are big changes. The usual change is a little bit less than 1 point per month. So the average patient with ALS would be right in this area right here. So we saw an improvement in the people who were taking edaravone.
Are there any studies now with the red label?
No studies in the United States. This is the report of the phase 3 study that was used to get FDA approval. It is now FDA approved. This drug will be available as of September, is what we're told. So it's not available right now. It'll be available in September. FDA has put no qualifications on who can be prescribed edaravone. So it's between the physician and the patient as to are they a good candidate for this drug. The people at MT Pharma have already reached out to infusion centers, ALS clinics, and everyone that they could possibly reach out to try to answer these questions and make sure that there's capacity, that there's enough room, that these centers are gearing up for the number of ALS patients that will want this drug. The result of this clinical trial is very exciting. However, we must remember that the 33% slowing of progression was seen in the drug group as a whole. If you remember the graph with all the blue and gold dots, you will recall that there was a great deal of variability between individual patients. The other very important thing to remember is that people did not get better on this drug. That is, they did not get stronger than they had been before they started the study. There was simply a slowing of progression in the drug group as a whole. The group that took the drug stayed stronger a little bit longer than the placebo group, by 33% as a whole. No one should expect to see a gain in strength, and it is impossible for an individual patient to see that they are moving along more slowly with the disease.